Shock can be a very scary word to hear in an in-hospital setting. So today we're going to develop an approach to understanding and managing shock. The first objective today will be to define shock. What does it really mean? Secondly, we'll develop an approach to differentiating the etiology of shock. And this is important because it vastly changes the way we manage the presentation and the patient. When we think about shock, what we're really saying is that it is a state of cellular and tissue hypoxia, either due to reduced oxygen delivery, increased oxygen consumption, or inadequate oxygen utilization. What it doesn't mean is simply hypotension. You can certainly have evidence of hypotension without any evidence of shock. Remember that oxygen is delivered by blood, which requires blood pressure. And blood pressure is a product of cardiac output and systemic vascular resistance. If systemic vascular resistance is low, that suggests vasodilation. Now, cardiac output can be thought of as a product of both stroke volume and heart rate. If you can't generate a sufficient cardiac output, this is either due to a decreased heart rate or a decreased stroke volume. And this could be due to low volume status, such as a preload issue, contractility, increased afterload, or sometimes valve dysfunction. Now let's think about the 4 types of shock. Distributive shock, such as anaphylaxis, sepsis, or neurogenic shock, can be thought of as severely decreased vascular resistance. Hypovolemic shock, which can be either hemorrhagic or non-hemorrhagic, is characteristic of low preload or decreased volume status, resulting in decreased stroke volume, decreased output, and decreased blood pressure. Cardiogenic shock is a measure of decreased contractility of the heart, which also decreases our stroke volume, decreases our cardiac output, and again decreases our blood pressure. And finally, we have obstructive shock, which is a result of high afterload, reducing our stroke volume, cardiac output, and again, blood pressure. So to review, we have 4 main types of shock: distributive, hypovolemic, cardiogenic, and obstructive. Now that we understand the theory, let's talk about how to clinically differentiate the types of shock. The first step is to differentiate whether we have cold shock or warm shock, and this can be done by examining the skin over the knees for both warmth and mottling. Warm shock is suggestive of distributive causes, while cold shock suggests low cardiac output. Then we should think about whether the cardiac output is low because of stroke volume or heart rate. Low heart rate suggests bradycardia as an etiology for hypotension and shock, whereas a high heart rate suggests that the etiology of low cardiac output is due to a decreased stroke volume. If that's the case, then we should consider the volume status of the patient, and this can be done by looking at both the JVP and also the response to fluids. An examination with low JVP or response to fluids suggests hypovolemia as an etiology for the shock. For patients with a high JVP or no response to fluids in this situation, we want to consider both cardiogenic or obstructive causes. And to do that, we take a look at the heart. Clinically, we can use a pulsus paradoxus, or we can use ultrasound for point-of-care testing. No pulsus on clinical examination is more suggestive of cardiogenic shock or decreased contractility, whereas a pulsus paradoxus on clinical examination is suggestive of obstructive shock or increased afterload. I hope we have a better understanding of shock, how to clinically differentiate the types of shock, and feel more comfortable managing these patients on the ward.